personalization part, and I know in the agenda we had something scheduled around DNA, mobilizing your DNA. We had a change in the program about a week ago. It had already been printed, and I apologize for that, but I promise you won't be disappointed by our replacement. So this next session, I'm thrilled to welcome our next keynote presenter, who has been leading the charge to bring digital health solutions to solve one of the world's most dire and chronic diseases, that is diabetes. WellDoc's work, I think you even saw them already mentioned a couple times in slides, in helping those with diabetes is bar none, and their integrations of AI and machine learning are some of the most promising for this ongoing epidemic. So let's welcome to the Digital Health Summit stage, WellDoc's Chief Strategy Officer, Dr. Anand Iyer.
In many ways, what we're talking about is, imagine a new drug in diabetes, and imagine that this drug has been through all of the randomized control studies, clinical evidence, proof, published in peer-reviewed journals. In fact, the outcomes are 3 to 4 times better than insulin alone. You're like, okay, check mark. And it's been through the hands of the FDA, like any new drug would be, right? Patient safety, good use, good manufacturing process, all that good stuff. And it can be prescribed. In this case, this drug is listed like every other drug in drug databases, and it can be therefore prescribed by a doctor, and it can be dispensed if you choose to have it dispensed by a pharmacy. But imagine if everything I just said were true, if the drug itself were a mobile app. Software is a drug. So this concept of digital therapeutic that you heard about earlier on, we were the first to get cleared way back in 2012. And what I'd like to show you today is kind of how we're using machine intelligence to push that envelope further and to deliver, if you would, the sweet spot of both health outcomes and economic outcomes. So for those of you who are, just a show of hands, how many people are familiar with diabetes as a disease, mechanics of diabetes as a disease? Fantastic. So I'm not going to dwell on this, but suffice it to say that it's not just a problem of incidence here, okay? It's a problem of incidence everywhere. And when you think about it, whilst we have here, 30-odd million people who have the disease, the scarier part is the CDC says 1 out of every 3 people born after the year 2000 will actually develop it. And what's the #1 cause factor for it? It's obesity. And so the age of diagnosis of diabetes is dropping as we see this epidemic in childhood obesity. At the same time, the impact is actually very significant. So in the United States, out of our $2.3-odd trillion we spend on healthcare, 10% is spent on this insidious disease. And the honest truth is, we feel badly because we need not spend that kind of money. A lot of these costs are actually avoidable. And if you think it's a problem here, our incidence of diabetes in the US is what, 8.5%, 9%? If you go to China, it's 14. If you go to India, it's 16. If you go to the GCC, the Gulf Cooperation Council, the 7 countries in the Middle East, it's 32%. So 1/3 of their people have diabetes. So this is not just an epidemic, it's a pandemic. And the honest truth is there's a lot of stuff happening in this. There's a lot of stuff in terms of new meters and new technologies. And in fact, if you actually look at the drugs that have come out, look at how much drug development has happened in the last couple of decades. At the same time, look at how outcomes have changed. In fact, outcomes are getting worse. So there's a primary metric in diabetes called A1C, hemoglobin A1C, which in simple English is the amount of sugar in your blood. It's measured as a volumetric percentage over a 3-month average. And that number should be 7%, which in English means 7% of your blood volume is sugar. Now, the reason that number should be 7 is that every 1-point delta, 7 to 8, 8 to 9, represents a 42% increase in the risk of heart attacks, kidney failure, blindness, amputation, stroke. And so you can just think about where we sit. It's interesting. We just did a study with the Military Health Services. The Military Health Services, MHS, the average A1C is 9.3, okay? Their full population. Just imagine how broken. So 80+% at risk for developing these both micro and macrovascular complications. So we need the drugs. You can't swallow apps. You need the drugs. Of course you need the drugs. But we're not hitting this nail on the head. And so we ask a very simple question. Are we solving the wrong problem? I love the picture. The guy's arms broke and the vase stayed intact. Are we solving the wrong problem? And I would assert that not just for diabetes, but really for any chronic condition, there's really 2 problems we need to solve. One is the right data is not getting to the right person at the right place at the right time. But you know what? Every other industry, retail, manufacturing, financial services, everybody has imported wireless technology into their supply chains, into their practices. They've all solved that problem. So why not in healthcare, right? Why can't we also take that approach where we can deliver, if you would, connectivity and not just data, but information, knowledge, and action? And that's the harder problem. It's easy to send data. What do you make of the data? I walk into my doctor's office when I was first diagnosed, and I'm a little bit of a nerd, so I would actually draw in Excel and graph and say, here's my glucose results. What's the doctor going to do in a 2-minute office visit? The human eye isn't trained to do that kind of pattern recognition, right? So we need to start with data, of course, but we need to extract value from data to convert it to information, knowledge, action, and of course, outcomes. So what did we do? We built this product platform. It's called Blue Star that I'm sure many of you have heard of. And what Blue Star is, it's fundamentally 3 things. In the upper left, you have, or the upper is no left here, it's a center picture. In the center, you have the patient app. So that's an app that's available to the patient either on their mobile internet device, smartphone, tablet. It's also available on a PC browser for those who want to use it. It's actually fantastic to see data. There's a discriminant function at the age of 69. And above the age of 69, 72% of readings into Blue Star come via the web. And below the age of 69, 87% of readings come in via the mobile app, which is actually quite fascinating to see something magic with that age of 69. But what that app does is it provides coaching at the point of care that's precise to the patient. So if I have drug regimen A and I have comorbid condition B, C, and D, my feedback for a glucose value may very well be different than anybody else's feedback because of those parameters that may be different for you and different for me, right? So it provides, if you would, that contextual real-time guidance right to the patient. At the same time, no doctor wants to be bombarded with all this data. I can imagine 8 years ago when we started this endeavor, doctor said, are you going to SMS me every single piece of data from all these patients? We're like, hell no. What are you going to do with it? What they wanted was a report. And they wanted to say, hey, tell me this is where they were, this is where they are, this is what's changed, this is what evidence-based medicine suggests I should do, but you're the doctor, do what you think is right for your patient, right? And what's fascinating, and I'll talk about it when we get to the outcomes, is to see how physician adoption and physician prescribing behavior fundamentally changed in clinical trials. Okay, so you have that piece, which is a smart visit report, which is this clinical care decision support. And then lastly, if you can imagine, if you're a Kaiser or a United or an Aetna, you want to be able to manage a population of patients, and so you have the population. So when we think of the platform, think of these 3 pieces working, if you would, in conjunction with one another. And what it does, you kind of see it here. I'm not going to go through the details, but suffice it to say, diabetes is a disease, like other chronic conditions, that needs you to manage very closely 6 vectors. You have to manage your medications, of course. You have to manage all your metabolics. In this case, it's blood glucose, it's blood pressure, it's lipids, it's weight, it's all the things that govern, if you would, your diabetes wellness. You have to manage your activity. And it's not just exercise, it's also sleep. How many articles in New England Journal of Medicine in the last little while have talked about the effect of sleep on diabetes and diabetes wellness, right? You have to manage your food. There's actually a really cool function inside the product that you can enter food and it'll tell you, how many portions to eat, et cetera, but there's also a restaurant locator. So it uses the GPS on the phone to actually find the nearest restaurant, pull down the menu, and filter out what's actually healthy for you to eat. We did a program with the Trucking Association of America, and it's actually fascinating. You say, you know what, don't pull off at exit 45. Go to exit 46 because you have 2 more restaurants that actually have things that are good for your carb range that you should have at this specific meal, right? And it manages all the psychosocial symptoms. It also manages, if you would, all of the behavioral aspects. You want to provide motivation. You want to provide affirmation. You want to provide confirmation at different points in time. And it does it in this very simplistic journey that's connected, if you would, to other devices. So for example, I can connect it to a blood glucose meter, that's Bluetooth. I can connect it to my Fitbit, to my Jawbone. I can connect it with my Apple Health Kit, my Samsung Health Kit. And in many ways, what you're doing is now, you're unleashing the power of data because now you're taking in all of this contextual data. So let's walk through what some of that data is. And when you think about it, a lot of people have heard about these 5 V's, right? There's variety of data, there's volume of data, there's the veracity, the truth of the data, if you would, and then there's the velocity of the data. So think about healthcare today. I would assert all of healthcare data, the vast majority of it, sits in that bottom quadrant, where we're collecting data at a low frequency, say maybe once a year, because you get it when you go see your doctor for your annual physical or whatever, right? And it comes directly what? From a system, from a lab system, from an EMR, from a PHR, right? From a lab, et cetera. But what Blue Star and what all digital therapeutic products aim to do, so don't just think about this as diabetes, really expand this to any other chronic condition, is you're now expanding 3 vectors of data. And you can see them here. There's high-frequency data now, and the high-frequency data is coming from where? It's coming from the system. It's time to take your meds. In fact, it's time to take your 4 units of Lantus, because that's what you need now, versus it's time to take this much after lunch insulin because you had this many carbs. So the system itself is providing data, if you would, in a high-frequency basis. The patient, of course, is providing high-frequency data. And then there's low-frequency data that's actually coming from the patient. What is that? That's their med regimen. It doesn't change every day. That's their preferences. Imagine a patient who's naive to insulin. Maybe in the beginning, I remember, this was a couple of years ago, where my doctor started me on insulin. I consider myself a somewhat educated guy. I couldn't inject myself. Don't ask me why I couldn't do it. And my wife's a physician, and she goes, I'll do it for you. I said, that's not going to work when I'm traveling. You're not there with me. And I sat with my doctor, and he says, look, give me an insulin pen. And he lifted his belly, and he wiped off some alcohol, and I said, what are you doing? He goes, I just want to show you it's actually easy to do. I still couldn't do it. Right, wrong, or indifferent. But maybe in the beginning, I needed a little support, a little coaching that said, you know what, here's how you should do it. Maybe ice it off so it won't hurt. But after I got the gist of it 2 months later, maybe I don't need to see that video anymore. That's what low-frequency data is coming from the patient. It's their own personal preferences, right? So if this is the data you collect, now the game is, what do you do with the data? So this is actually an interesting framework. We've presented this to the National Science Foundation. They're actually going to adopt this idea as their moniker for data science in digital health, which is, you see the axes here. So I have status of data. I have it or I don't. And you have the y-axis, which is what my analysis intent. I know what I'm looking for or I don't. So play it out. In the bottom quadrant, I have data. I know what I'm looking for. We call that as informative. Informative answers the question, tell me what happened. Hey, show me the percentage of readings that came in on mobile versus web. Or show me how women did versus men. Or show me how insulin versus non-insulin patients did. You graph the hell out of the data you have. And once you've done that, you then go north. And then when going north, we call it D-discovery. And discovery says, okay, I have data, but I don't know what I'm looking for. Can I learn something from the data? And it answers the question, not tell me what happened, but tell me why it happened. Why is it that this trend is occurring with this patient group on this drug regimen on this day of the week? Example, right? And so here you want to look for what? Exercise patterns, glucose patterns, medication patterns, skipping medication patterns, whatever your favorite pattern is. And once you found the pattern of interest, you now come down to E-extrapolate. We wanted to call it P-predict, but IDPA doesn't spell anything, so we call it E-extrapolate, because IDA spells something. E-extrapolate says, can I predict? Can I actually predict? And I'll show you examples. It's actually really cool where this goes. Can I predict, for example, the incidence of hypoglycemia? Imagine how cool would it be, hey, mom, tomorrow between the hours of 3 p.m. and 5 p.m. in the afternoon, make sure you're carrying some glucose tablets, because you're probably going to go low. By the way, out of the 245 billion we spend on diabetes every year here in the United States, some 38 to 42 billion is unnecessary hospitalizations due to hypoglycemia and hyperglycemia. You can wipe that out. You can wipe that cost out. We'll talk about economic ROI in a second, right? And then lastly, you adapt. And adapt says, I neither have the data nor do I know what I'm looking for. That's called learning. I actually changed the parameters of the software on the fly. So what does it look like? Let's give a couple examples. So in informative, here's 2 patients, John and Mary. They both have the same reading after lunch, but they get very different feedback. Why? Their medication regimens are different, and the context of that number is different. So unlike just picking up Google and say, what do I do with the 226 mg per deciliter? What Mary and John have to do may be very, very different. So informative says, can you inform at the point of consumption, at the point of care? Can you be precise about what you actually tell them to do? Then there's D-discovery, right? So why did it happen? So here, you're looking at correlations between blood glucose and in meds, blood glucose and exercise, blood glucose and sleep, and you're looking for what? You're looking for patterns. So it's fascinating. The highest used feature in our product today is meds. The second highest used feature is blood glucose. The third one is actually viewing a logbook. The fourth one, you'll never believe it, the fourth one is notes. So structured and unstructured notes. Unstructured notes, people put in free text. They had a reading of, maybe their after lunch reading was high. And you know what they're writing? The average length of a free text is 54 words. 54 words, guys. They're not just saying, yeah, I'm feeling good, or, I'm feeling down. They're like, I went to Ricky's and I had the extra slice of pizza and I shouldn't, and next time I'm going to try to be more careful. So now our friends at, you can imagine the three-letter company that we're working with, who does all this machine learning and language stuff, natural language processing, can I extract sentiment? Are they confused? Are they worried? Are they afraid? Or, best of all, do they feel in control? And are you empowering them to take control of their disease through machine learning and data, right? Then you have extrapolative. So I talked about hypoglycemic prediction. We just received our 7th patent for the company, and this was the patent we received, which is, it's very easy, it's easier to predict when you actually have continuous data, like coming from a continuous glucose monitor. It's very hard mathematically to do predictive modeling with sparse data. So look at the pattern here. Look at the glucose readings, 111, 141, 110. They all kind of look sort of in range, right? Whereas when you actually run it through our machine learning algorithms, it tells this, in this case, on day 8, that they're actually going to be hypoglycemic. Why? They're not just looking at the glucose vector, they're looking at the notes, they're looking at the activities, they're looking at the carbs. And the machine learning has come back and said, you know what? To the nearest hour on the 8th day, this is what's going to happen. And sure enough, when you show this pattern to a physician versus you show it to a machine, guess what the machine figured out? That it was going to be hypoglycemic. And sure enough, that's what happened with the patient. Why do I say this? It's not to replace physicians. When I'm sick, I want to go see my doctor, is the honest truth. But it's an adjunct. It's a value multiplier. Imagine, the space shuttle never flew without a pilot. It always had a pilot. But the pilot didn't control the million simultaneous variables that needed to be controlled. Well, chronic diseases are like that. So you need machine intelligence and, if you would, this power of computing to help provide the patient and the provider in many ways. You're taking the patient and the provider and you're letting them stand on technology's shoulders. They can reach further, they can reach higher, which is really cool. And then this is adaptive. This is really cool because adaptive says, can I keep something from happening if it's a bad trend? So if I'm skipping my meds, or if I'm having recurrent hypoglycemia, can I actually prevent? In this example, a patient had a low, and then they were going to go and exercise. But the system detected that they were already low, and they said, hey, first of all, go and exercise. Great, good for yourselves, good for your body. But you were just low. Make sure you take some rapid-acting carbs with you. So adaptive says, can I change the software on the fly, right? And in this case, this is a good pattern. In this case, this is a fun one. Person's had too much to eat for lunch. Well, normally you would say, well, take extra meds, or take an extra shot of bolus insulin. But now the system has been tracking the correlation between their walking steps and their drops in milligrams per deciliter of blood glucose. And it says, hey, you know what? You have a choice now. It's actually sunny today outside now. And you can walk your 800 steps and you'll drop by X number of milligrams per deciliter. And patients love choice. You give them choice, whether it's like how when you drive in your GPS in your car, I want to avoid tolls, I want to avoid freeways, I want to avoid whatever your favorite. You pick what's right for you. And in many ways, this allows that kind of personalization for patients, which is just, it's ultra cool. As a patient myself, I'm like, that's way cool, right? So now, how is all of this of relevance, and why is this of relevance? What we've shown time and time over again, over 30 published clinical journal and posters, what we've shown is that when people use this system in conjunction with their provider, they drop their A1Cs by over 2 points on average. By the way, those people who start with A1Cs above 9, the average drop is 3.5. That's wild. You know why? the FDA requires a drug, a new drug in diabetes, to drop it by half. That's the benchmark. You're talking 4x to 7x of what that drop is, using software as a value multiplier, which is a really, really cool thing. And if you look at the top 15 drugs in diabetes today, they average a drop of 0.8. So it's like, well, that's cool. But then what we did was we worked with our friends at Truven Analytics, now an IBM Watson Health company, and they said, hey, if you can actually tell us, put it into a matrix where you have, okay, I have 1,000 patients in my population, and here's the starting distribution of A1Cs. You know, X% start, you know, between 7 and 8, Y% between 8 and 9, blah, blah, blah. We, WellDoc, can tell you where they'll end in English. You tell me where they start, I'll tell you where they'll end. And they said, hey, we actually have cost data for every one of those bands, because they have this market scan database, amazing database that has like some 122 million patients worth of actual adjudicated claims data in the United States. And they have labs for those people. So they said, hey, marry the two data sources together, which is what we did. So they actually told us, this is what the costs are. These are the costs, and you can see here, I've put it on the left for commercial and the right for Medicare. These are the actual costs that are incurred by patients, and you can see no surprises. The more out of control you are on the x-axis, which is A1C, the higher cost you have. And by the way, cost here is total cost. It's the cost of acute, what they call acute utilization, which is ER, admits, hospitals, and then doctor's office visits. It's supplies, meters, strips, and drugs, so pharmacies included, and of course it's comorbid costs. Usual suspects, hypertension, hyperlipidemia, nephropathy, neuropathy, and retinopathy, right? The 5 big comorbid complications of diabetes. So in English, if I can take the guys on the right-hand side of the graph and shift them over to the left, I ought to be saving you money, right? And it's actually something that we just announced last week, which was fascinating, that said, if you actually take this and you walk into a health plan, you can pretty much predictably tell them that this is what you're going to save on average, you're going to save somewhere in the $254 to $271 per patient per month. And by the way, that's an average. The upper range of that goes to in excess of $470 per patient per month. Now, remember what those total costs of diabetes were? If you're taking off $400 per month, you're taking almost $5,000 off a $12,000 or $14,000 expense. You have put a significant dent in the health outcomes, and you've put a significant dent in economic outcomes. And how? What's the magic ingredient here? There's only 2 magic ingredients. One is data science, the power of machine intelligence. One is the engaged patient. In fact, I say this tongue-in-cheek, but I'm dead serious. The blockbuster drug of this century is what? It's the engaged patient. Get them to do what they're supposed to do, and all of a sudden, good things happen. So I'll leave you with this one thought, which is, at the end of the day, this is all fantastic. Great A1C reduction, cost reductions, machine intelligence, blah, blah, blah. But I'll end it with the personal note, which is, the worst thing about having a chronic disease, guys, is that people get lonely. How many diseases have undiagnosed depression as a side effect of their condition, whether it's diabetes or asthma, or whether it's COPD, CHF, anything? And when people are lonely, bad things happen. And you go down this abyss, this spiral of misery. And if technology can be what lifts them out, if artificial intelligence is what gives them hope, as you saw with the earlier presentations too, then we all wake up in the morning thinking we did something good. So thank you very much.